Hi, Scott Miller. Welcome to my Top Performance blog, and I am talking to Dr. Stephen Michaels.
Thank you.
And it's great to have an opportunity. You're here at the ACE conference in Kansas City, but you're kind of an old hand at this stuff. Tell me what you're doing.
Well, we actually, right now, I'm the director of the Arizona Smokers Helpline. It's the state quit line for tobacco. People want to quit smoking, they give us a call. We set them up with what we call tobacco quit coaches.
Okay.
About 4 years ago, we decided, because I'd been working on this for a while, to introduce the outcome rating scale and session rating scales with our staff to start measuring outcomes.
Wait a minute, do you meet people face to face?
No, we actually do everything over the phone.
Okay. You're using these measures over the phone.
Yeah, it was actually great since they were tested that way to actually be able to go back and say, okay, we're going to use them on the phone just like they were used in some of the tests.
And quitting smoking, that's what you're helping people with.
Yes, we are. And we're getting great results.
Well, can you tell us something about that?
Yeah, one of the things that we've done now that we have to report our outcomes, we're actually able to compare ourselves to other quit lines. And what we're seeing in some of the bigger quit lines is quit rates around 19 to 28%, and we're getting quit rates of somewhere between 34 and 37%.
And when you say that, can you help me know, when you say quit, so they're abstinent from cigarettes, no cigarettes for what period of time?
In the tobacco industry, or the tobacco quit industry, quit means no cigarettes within the last 30 days at the point we call you. We call people 7 months after they enroll in our program, and at that point we ask them, over the last 30 days, have you used any tobacco?
Okay. And your results are, nearly double.
Nearly double what a lot of the other quit lines are.
And what do you attribute that to?
Well, we're actually looking into that now, and we think there's some basic things that we're doing differently than other quit lines. One of them is we really have taken to heart individualizing what we do with people.
Okay.
So when they call in, we really assess where they are in their quit. Is this the first time they've quit? Have they quit 100 times? And really, that gives us some groundwork to start on. Because if they've quit before, as we tell them, every time you quit, you become a better quitter. So we want to build on what you learned from the last time.
Kind of deliberately practicing quitting.
Exactly.
Okay, perfect. And now, that's one of the things you do.
Yes.
One of the things you're doing different. What else you think you're doing different that leads to such different results?
Well, one of the things that we've done with the outcome rating scale, what it's allowed our coaches to do, or counselors to do, is really focus on like one item. They only get to talk to people for 15 or 20 minutes.
Yeah.
So we try to get that pretty narrowly focused in that 15 or 20 minutes, and the outcome rating scale really gives us a place to start. If there's an indicator on any one of the 4 questions, that gives them a place to start and say, do you think that's impacting your ability to quit right now?
You have a 15-minute phone call.
Correct.
Not an hour.
No.
In an office.
Correct.
Relaxed with a cup of tea or coffee and a bagel.
No, it's a little hectic in a cubicle with a headphone on.
And 50, what's interesting to me about that, just an association I'm having, is something that Nick Cummings, who is kind of one of the visionaries in our field, has been saying, which is that if therapists want to be respected, they, number one, have to integrate into the broader healthcare system, and number two, they have to give up the notion that you can only help people if you see them for 50 minutes.
That's correct. And we talk about that a lot, because some of our calls tend to be less than 8 minutes. If somebody's doing really well and they're following a plan, because we ask everybody to write their plan down, and if they're following their plan and they're doing a great job, we don't want to give them something to worry about. So we always tell our staff, if you're working with somebody and they're doing a great job, continue to encourage them, help them set a goal for the next time, and if you're done in 8 minutes, you're done.
Wow. So the second thing is then using the outcome measure to track progress and to have discussions with clients about that, both when it's working and when it's not.
That's correct.
And was there another thing, or am I just imagining that?
Well, the other big one was the session rating scale helped really hone in who's doing a good job and who's not. Because one of the things we've discovered in looking at some data over the last 3 years is that there's huge differences amongst our staff. Some people have really good engagement skills, some people get really good quit rates. We tend to find that the two go hand in hand. The top 2 people on our staff tend to have the best quit rates amongst their clients and also have the biggest engagement numbers.
And, when you say, the difference between 19 and almost double that, what kind of impact is this having? I mean, are you getting attention, or are you the butt of jokes that you must be making it up? What's happening?
We get both of that. We get a lot of quit lines who believe in what we're doing, who've been using some of the old standard practices, who have asked, whatever it is you're doing, we want to know how you sold it. We hear that a lot. How did you sell that to the state so they allowed you to do this? And fortunately, Arizona took some rather grandiose steps. The CDOI principles were actually accepted as a best practice, so it was an easy sell for me to piggyback on that from behavioral health into the health department and say, look, they're already doing this with behavioral health. We are another arm here in health department, so we want to use this as well.
Whereas other states are more emphasizing the specific model of treatment or something.
The evidence base that's supported in the public health guidelines.
Wow. Hey, thanks, Stephen, for talking to me.
You bet. I appreciate it, Scott.